live with Dr. McDougall today, and this is the weekly webinars that we do. Today I'm in London, so we might have a few little bumps in the road, but hopefully everything will work okay. I will pass it on to Dr. McDougall and welcome you and thank you for being in California and talking to all of us today as you do every week. Welcome, Dr. McDougall.
Thank you. I'm really happy to be in California. You know, Europe seems to be a pretty exciting place this time. In fact, next week you go to Paris, and I can only imagine what things are going to be like. Yeah, I can only imagine what things are going to be like there. Well, what I'm going to talk about today is we're going to just continue some of the discussion we had last week on diabetes, and I put together some slides, so to speak, to cover some of the material that we talked about last week and also to add some of the things that we were talking about last week. First thing I want to make clear is, unless I say otherwise, I'm talking about type 2 diabetes, the kind of diabetes where patients make their own insulin. I'm not talking about type 1 diabetes unless I specifically say so. A type 1 diabetic must be on insulin or they will not live. So this discussion is about type 2 diabetes. I prepared a few slides to go through. I'm going to go through them quickly, but as I understand it, I know you can watch this same presentation over and over again from my website, and so you can catch the references, you can look at the slides more clearly, and so on. I did in the year 2011 a lecture, about an hour-long lecture titled "Diet, Drugs, and Diabetes, 100 Years of Missed Opportunities." And you can play that video from my website free. Just go to the education section, then go under videos, then go under free videos, and you'll find this particular lecture, and I know you'll enjoy it a lot. I presented it to a few medical groups, and you know, as usual, I don't find people coming back to me and saying, you misquoted the literature, you exaggerated, it's not true. It's true. A fellow by the name of Huckaday wrote, "It is important to remember that diabetic control means a lot more than blood sugar control." You see, what doctors try and do worldwide is they just try and make the blood sugar look more normal. And medication effectively lowers the blood sugar levels, but the patients die sooner with better looking numbers. That's all they accomplished. To get approved as a diabetic drug, all you have to be able to do is lower the numbers. You're not required to have better outcomes in terms of death and disease in terms of your patients. You just have to make the numbers lower. One of the first drugs I was dealing with when I was a young student 40 years ago was a class of drugs called sulfonylureas. And back then, they reported that these drugs, over a 5 to 8 year period of time, increased the risk of death of diabetics by 2.5 times. And that was published in the PDR. This is a section out of the physician's desk reference, which is a special warning for increased risk of cardiovascular disease. And it appears next to every one of the diabetic drugs. We've known that these drugs kill, and we've known it since the 60s. What doctors base control on now is not just the blood sugar numbers. They use a measurement of a protein, hemoglobin A1C. What this is a normal hemoglobin protein in the body, and when sugars get attached to it, it distorts the protein. And for me, back when I first learned about hemoglobin A1C, it seemed like an explanation, a good explanation, as to why diabetics do poorly. Their proteins are all distorted by having sugars attached to them. And I think that is true. I think that's one of the reasons that diabetics are metabolically handicapped. They're weakened people. They can't defend and repair as well as other people. They get a sore on their foot. They could get gangrene easily. They lose their vision. They lose their kidneys because their proteins are all distorted. But what doctors logically thought is if we lower the blood sugars by giving medications, that the problems would be fixed. The distortions of the hemoglobin A1C, or the hemoglobin, which is the hemoglobin A1C, would be fixed and everything would be fine. But that's not what has happened. I want to go through 6 major studies with you on the aggressive treatment of type 2 diabetes. You can look these up later if you want, but these are all the studies that are available on treating type 2 diabetes. The studies were set up so that one group was treated casually. In other words, they got usual diabetic care, checked their blood sugar once in a while, maybe took a pill here or there. And the other group was treated intensively. In the first veterans study, they found a strong tendency toward worsening of cardiovascular outcomes in patients with intensive control. The TRACE study, one of the biggest studies ever done, it was done in Europe. Diabetic patients treated with oral hypoglycemic agents or insulin, but not those treated with diet alone, have a significantly increased mortality following acute myocardial infarction compared to non-diabetic patients. So this is the year 2000, 15 years ago. Doctors, scientists, this is without any questioning. There's no one questions this data, and there's nothing else to say otherwise. The ACCORD study was actually stopped 17 months early by the Heart, Lung, and Blood Institute because they saw such a great increase in mortality in the patients that were treated intensively. Intensive treatment was to try and get the hemoglobin A1C percentage level down to around 6% compared to the control group, which had a hemoglobin A1C level around 7.5 to 8.5%. So it was so poor that they had to stop the study early because they're killing so many people with intensive therapy. And that was published in 2008 in the New England Journal of Medicine. The next study that followed was the advanced study, and they found there was no significant effects of the type of glucose control on major cardiovascular events, death from cardiovascular disease, or death from any cause. And then we have the veterans studies, which showed intensive control. No significant effects on rates of major cardiovascular events, death, or microvascular complications, with the exception of protein in the urine. So 3 major studies that were published in 2008 showed that all the aggressive therapy that your doctors are doing to try and make your blood sugar look better and your hemoglobin A1C look better results in a worse outcome for the patient. They have more death, more heart attacks, more sudden deaths, more hypoglycemia. They have greater weight gains. It's a complete disaster what's going on, and nobody responds to it in a professional, proper, honest way to help the patients. There's just too much money involved. For a drug to be approved to be used, it just has to lower blood sugar. In 2008, the FDA asked the drug companies to be a little bit more professional and show there was an improvement in the health of the patients, but it was just a request. So, drug management: higher mortality, more heart disease, increased risk of sudden death, much more hypoglycemia. Hypoglycemia, you could get picked up by the police for a DUI if you get low blood sugar or fall over, and twice the weight gain in the intensive treated groups. So why do doctors justify still treating patients when we know that they cause heart attacks and deaths and so on? How do they justify treating patients intensively with drugs? Well, they say maybe it doesn't help major vascular problems like heart attacks and strokes, but they say it helps minor vascular problems or little microvascular problems. These are the tiny blood vessels that go to the eyes, the kidneys, and the nerves. This is the retina of the eye. You see the round red, orange circle there? That's what the back of your eye looks like, and that's the retina. And what they say is by using intensive treatment with various medications and insulin, they'll prevent hemorrhages and exudates and blindness. Here's a review of the studies that have looked at whether or not intensive control with medication reduces microvascular complications. And you can later take and study this chart more carefully, but I'll tell you what I see is that there's very little benefit when it comes to type 2 diabetes. When it comes to type 1, there may be some benefit. It is really a lot less than your doctors brag about. There is some benefit in controlling kidney loss and eye loss, vision loss, and developing diabetic retinopathy, but it's not much. And when you look at the patients with type 2 diabetes, the studies that were done, like the ADVANCE and the ACCORD and the Veterans study, what they show is not much. The advanced study and the veteran study maybe showed a little bit of benefit in terms of protein in the urine. It is surprising if you go through these research papers to see how little is accomplished. A review of the treatment of microvascular diabetes for microvascular outcomes came to the conclusion intensive therapy did not reduce the risk of advanced measures of microvascular outcomes. That was in The Lancet in 2010. And The Lancet published, they published about, this was about the ACCORD study, microvascular benefits of intensive therapy should be weighed against the increase in total and cardiovascular disease-related mortality, increased weight gain, and a high risk for severe hypoglycemia. So the questions are being asked by some of the scientists, but the practice continues. The British Medical Journal, their conclusion, the harm associated with severe hypoglycemia might counterbalance the potential benefit of intensive glucose-lowering treatment. Intensive treatment was associated with a significant reduction in only one endpoint, the rate of microalbuminuria, which is the amount of protein in the urine. The gist of what you should be getting is all this effort provided by your doctors, all this medication you're buying, all of this belief that you have, it's not true. It's not helping you. The research says so. The benefits are so minimal and their harms are so great. You ought to reconsider. I talked to you last week. I showed you some papers. Let me show them to you again. How sugar makes diabetes better and fat paralyzes insulin. We'll briefly go over the things we talked about last week. I talked about Shirley Sweeney taking care of his medical students. He put them on a high sugar diet. Look at the sugars he put them on. Sugar, candy, pastry, white bread, baked potatoes, syrup, bananas, rice, oatmeal. And he checked their blood sugars after this challenge meal, and their blood sugars responded normally. No evidence of diabetes. He did it with a high protein diet, and the blood sugars were higher on the high protein diet. So protein does increase diabetes. And then he did it on a high fat diet, and all of his medical students became profoundly diabetic right after the high fat meal, and the fat was olive oil, butter, mayonnaise. Right, here's one of the students. They took one student, they put him either on a high fat diet or high carbohydrate diet. And you see the difference in ranges in blood sugars. On the high fat diet, they were diabetic. On the high carbohydrate, high sugar diet, they were non-diabetic. This is Shirley Sweeney's basic work in 1927. I also talked to you about how increasing the sugar intake, this was done by Brunzell, New England Journal of Medicine, 1971. Increasing sugar intake actually made insulin work better. They had a synthetic mixture of sugars, maltodextrans, simpler sugars of 45% of the calories. They doubled it to 85% of the calories, and the fasting blood sugar level fell. The overall glucose tolerance improved. The fasting insulin was lower on the high sugar diet. Sugar makes insulin work more efficiently. As they say, these data suggest that a high carbohydrate diet increased sensitivity of peripheral tissues to insulin. I talked to you a little bit about Hemsworth's work that was published in 1940, again, showing over and over that high-fat diets paralyze insulin, create diabetes. High carbohydrate diets, even high sugar diets, do the opposite. The research is there. There's no controversy. Here's some more of Brunzell's work looking at insulin levels on the right-hand side. You see on the high carbohydrate diet, there's less insulin produced because there's less insulin needed. All right, let's see. We also talked last week about ongoing research. They took type 1 diabetics and added fat to their diet. The result was the fat increased glucose levels and insulin requirements for type 1 diabetics. So it's consistent, it's clear, it's been published over almost 100 years now that sugar, even white sugar, makes diabetics better, and fat paralyzes insulin and makes diabetics worse. And also think about something else. When I'm talking about sugar, I'm talking about carbohydrates like rice, corn, potatoes, beans, peas, and lentils. These are the things that reduce the risk of kidney disease and heart attacks and strokes and keep you thin and give you good bowel movements. When we talk about fat paralyzing insulin, it doesn't just do that. Fat impairs your circulation and promotes cancer. I mean, the message is clear and consistent, but the message to the patient is the exact opposite, and as a result, people are suffering terribly and unnecessarily. Treating type 2 diabetes with a high carbohydrate diet. We got a clue to that during the war years in England and Wales. They looked at the mortality rate for type 2 diabetes. And prior to World War I, mortality rate was increasing. World War I came about between 1915 and 1918. And because of rationing, in other words, you couldn't eat all the butter and the eggs and the bacon, the mortality rate decreased dramatically. Post-World War I years, the economy returned till we get to World War II, when rationing was again part of Western Europe's daily life. And as a result, incidence of diseases like heart disease and multiple sclerosis and diabetes and death from these diseases plummeted when people had to switch to potatoes and other vegetables as opposed to the meat and the butter and the cheese and so on. As an interesting guy I want to tell you about, his name's Rabinovich. He went around treating patients, thousands of patients all over North America. And he said in one of his papers, May I, however, observe that we now have over 500 patients on this diet, and that 16 failures among them is, at least in my opinion, a highly satisfactory state of affairs. He concluded back in 1930 that his patients would rather eat a healthy diet, a high carbohydrate diet, than shoot themselves with insulin. What a conclusion. He said things like a potential diabetic can be transformed into a completely diabetic individual merely by administering of the time-honored carbohydrate-free diet of meat and fat. That's what he said in his paper. Fat protein diets from which carbohydrates are excluded find no logical place in the present management of a diabetic. The diets are sufficiently attractive so that when given the option of being sufficiently underweight or taking insulin, the majority of patients selected the former course. 1930. Pritikin's results published in 2005. These are on about 4,000 patients. Many of them were diabetic, and the results are their blood sugars dropped by about 35 points. Most of the people got off of their oral agents, and many patients were able to stop and reduce their insulin. James Anderson, University of Kentucky, showed that 10 of the 20 patients who were on insulin, who had type 2 diabetes, were able to get off the insulin completely. He got almost everybody off of diabetic medications. That was University of Kentucky. James Anderson published that. Neal Barnard is publishing data these days from PCRM. That's where Neal is located. And showing that diabetics do much, much better when they eat a vegan diet in the American Diabetic Association diet. The vegan diet happened to be the diet that I teach. And he's also recently published results on helping people with peripheral neuropathy, in other words, pain in their legs and feet. Walter Kempner, back in the 30s, 40s, and 50s, he published results on treating type 2 diabetics. He fed them a diet that was 93% sugar, 93% carbohydrate, and it got the same results. Patients with type 2 diabetes were all cured, and patients were benefited greatly. Here's one of his patients. If you look on the left-hand frame, you see these white areas. Those are exudates. If you see these red flared areas in the back of the eye, this is the retina. I showed you the retina of the eye a few slides ago. If you see the red flares, those are aneurysms and bleeding in the eye. Put them on the Kempner diet, which is a very high carbohydrate diet, and you see the results of the same man's eye. About 2 years later, you see the exudates have disappeared, the hemorrhages have disappeared, the aneurysms have disappeared. And the way we treat this condition today is with laser therapy, which destroys the retina. All right, well, we are getting no more slides. I guess that's enough. I guess the slide presentation is done. All right.
That's very good.
Okay.
Dr. McDougall, yes, you are on camera because I have turned off my due to the quality. But I think that everybody in this webinar, along with me, is wondering you have presented amazing, absolutely incredible, amazing
And
scientific
it's true.
research that really, and it's true, and it has no
That's true.
controversy. I mean, now, what is it? What is it going to take for the medical uh, profession to start looking at this and doing something? What's going on?
I don't know. It's the same thing with coronary artery bypass surgery for people who have chronic coronary artery disease. They're just making money. That's the only explanation. They're just making money. They learned a trade. They learned how to cut somebody's chest open and make make $500,000 a year doing it, and they're not willing to do anything else. Same thing with the MS drugs. It costs $75,000 for the medication for a multiple sclerosis patient, and the drugs don't work, and they hurt people. This is criminal behavior, but somehow or another, no one has stepped up because they're all making too much money. That's why they're not stepping up. There's just so much money being made. Why would they do anything about it? But
I know, but we're dealing with people's lives. I mean, it's just unbelievable. Oh my God!
That's why, Gustavo, they cheat and make fake computerware to measure the pollutants given out of Volkswagen diesel engines, and that's why they make airbags that kill people, because it's cheaper to cheat. You make more money cheating. That's why. It's just human beings.
Yeah.
Human beings.
Yes,
There's no other explanation. It's just the money. They act, and I'm not going to say that you and I are of a special grade above other people. It's just that's the way people act. They want to make money. If a few people get hurt along the way, so be it. But there's billions and billions and billions of dollars being made cheating and lying.
Right. Dr. McDougall, would you just take a few questions? We won't have a lot of time today, but maybe just 4 or 5 questions. Would that be okay?
Let's do that. I want to make sure that you remember that all the things that I talked about in those few slides and much more is in a video that I did that's on my website, drmcdougall.com. You just look under education videos, and there are free lectures, and you'll find it down there. Drugs, Diet, and Diabetes: 100 Years of Missed Opportunity is what it's called. And you can look at the video. You can go look all the scientific papers. You can go to your special friends and doctors and scientist people and say, why is this wrong? What am I missing? Show me the other side of the story. I always have fun with that. Show me the other side of the story.
Right, yes.
They don't want to talk about it.
No, they just don't, and they ignore it. Obviously, they would have to give up a lot.
This is your mother. This is your dad. This is your grandfather. This is your children that are dying and suffering because of this misinformation.
Well, there is someone here on the call, just like you were saying, who has an 18-year-old son, and so of course this is very personal, very important, and she has a question. That she says that her son has been diagnosed with insulin-resistant diabetes, and he's 18 years old, and if it's okay for him to eat brown rice and potatoes and pasta and bread. Well, what do you say to that?
Well, this is what we call type 1 diabetes, I assume. Type 1, he's missing pancreatic function, and it's not going to come back, and so he has to supplement with insulin. Is it okay if he eats the foods I recommend? It's life-saving. It'll keep him from having complications of the kidneys and the eyes. And the Western diet of meat and dairy and poultry and so on, it causes eye damage and heart damage and kidney damage in people without diabetes. You take somebody that's metabolically handicapped, like someone who has type 1 diabetes, and they just fall apart at a rampant rate. Within 11 to 17 years after the diagnosis of type 1 diabetes, almost all of the patients have major complications. So you can prevent those complications even if he has lost his pancreas by feeding him the kind of diet I recommend. You can stop the eye damage, you can stop the kidney damage, you can give him a chance of living to be a ripe old age. I've seen it before. I've seen only a few patients who've been treated with a high carbohydrate diet who are type 1 diabetic, and I remember these people as being in their 40s with not a sign of diabetes complications. Of course, they have the missing pancreas. Yeah, absolutely. Why not? Why not? Why would you feed dangerous hamburgers to somebody who's sensitive as your son is?
Right.
Or the meat eater's pizza, or the cheese lovers pizza. Why would you feed them that? It kills
It's poison. Yes,
Yeah, it kills,
exactly.
gives half of the American pre-diabetes.
Dr. McDougall, someone is asking, Bernadette is asking that last week you mentioned how you stop all meds with diabetes the first day of your 10-day program if the patient has a good pancreas. So what kind of test do you
This is a judgment thing. I've been doing this for 40 years. And some of the things I use to guess whether or not the patient is making sufficient insulin so that I can safely stop their insulin, which could be as much as 300 units of insulin a day or 150, and a half a dozen diabetic pills. I talk to the patients, and as I say, it's guesswork, it's judgment. If somebody is very overweight and they're on multiple medications and they tell me they're clearly a type 2 diabetic and that they've never gone into ketoacidosis, and sometimes their blood sugars get quite low, they have frequent hypoglycemic reactions, I know they're taking too much medication. And because I only have them at my program for 10 days, I've got to move fast. And so my guess is that they're really a type 2 diabetic, or at least a strong type 1.5 diabetic. I just tell them, stop all your medication, because if I don't, they'll have hypoglycemic reactions and they'll fall down on the floor. And somebody's going to come to me and say, well, why did you keep them on those medications? They had hypoglycemia and got in their car and drove into somebody and killed them. I've got to move fast. So what I do is I take them off all their medications first day, if I believe that they make sufficient insulin, and then I follow them every morning. I just check their blood sugars in the morning, and I hope their blood sugar is, well, if they're off medication, it can be as low as it wants to be. But I hope their blood sugar usually it's about 150 to maybe 300 if they're a type 1.5 diabetic. If they're truly a type 2 diabetic, after a few days, they're coming down to around 100. And after they lose all that fat, 100% of the time, a type 2 diabetic will be cured of their type 2 diabetes.
Right. Could you tell us, Dr. McDougall, one more time in a little more detail how to find that video so that people can, by going to your website?
You go under education, and then under education, there's a section called videos. And then there's a section called free videos, and I think it's the third video down. Or you could just look up, go to the search engine, just look up diet, drugs, and diabetes. That'll do it. 100 years of wasted opportunity or missed opportunities. Shouldn't have any problem finding the video. Right. And it's free. Good. Like everything on the website, it's free, except your trip to Hawaii with us, which we are going to be charging for, which is January 30th, by the way. So we'd love to see more people come along with us to Hawaii. And I think we have another 10-day program coming up in December. You'll see that on the website too. And there, if you come, I will help you personally make these changes and guide you through the diabetic process of getting off your medication, if possible. Remember, some people have to take insulin, and I usually give long-acting insulin called Lantus. And I always give insulin to type 1 diabetics, and to type 2 diabetics, I give them a little bit of Lantus so they don't lose too much weight, develop symptoms of diabetes such as excessive urination, and or if they worry about the numbers, I'll give them some Lantus to poke themselves with so that mother-in-law doesn't worry, doctor doesn't worry, they don't worry. Right. See, we're doing medicine, we're shooting ourselves, and our blood sugar is a little bit lower. So I'm a full-fledged doctor. I take care of all parts of the body, including the mind. And I don't want them to get worried. So I give it then too. Right. But I never give pills. The pills are dangerous.
So you prefer the insulin over the pills?
Yeah, because I showed you the sulfonylureas. We've known since 1970 that they increase the risk of dying of heart disease by 2.5 times over a 5 to 8 year period of time. The other drugs are associated with heart failure, all kinds of problems. These medications are. And people say, well, what about glucophage or metformin? Well, that has fewer complications, but most of the patients I have on metformin, they've got gastrointestinal distress, and who knows what other problems they'll develop. If you want to read about the side effects of metformin, just go to the internet. Way too many side effects. Benefits, pretty close to zero.
I know.
Except the blood sugar looks a little lower. You know,
Right.
the benefit is the blood sugar looks a little lower. The doctor thinks he or she is doing something for the patient. The patient thinks he or she is doing something for herself. But the truth of the matter is the benefits from metformin are minimal and questionable. They presented some minimal benefits from this drug, but certainly not comparable to eating a potato. Huh. Why eat potatoes? They're free. Why not take pills? People are getting rich.
Right. Nobody's getting rich eating potatoes, right?
And by the way, potatoes are great for diabetics. I know you've been told otherwise.
Exactly. Yes, actually, I had someone submit a question about that, saying that a doctor told her that eating sweet potatoes was good, but not potatoes.
No, well, that's not true. There's so little physicians and dietitians know that is true and effective. They get little tidbits of misinformation. They go to meetings that are paid for by Kraft and the dairy industry and the meat industry. They put up all the booths and bring in all the speakers. And I want to tell you, the only speakers that get to speak at these meetings are those that promote their products. They never invite me.
You mean you don't get invited?
I get no invitations. I feel so lonely. It's criminal. It is absolutely criminal. When people,
it really is.
When people take your money and hurt you, it's criminal. They're called criminals. Criminals.
Well, yes. I mean,
but they're nice.
You are hurting. They're nice. Yes.
Yeah, they'll your next door neighbor and your cousin and they don't think they're doing anything wrong, but they're criminals.
They have nice cars and nice houses, so
they go to church.
Right.
Everything's fine, but they're hurting people, and they know it. They have an inkling that they know it. They know there's something wrong. I mean, none of the patients ever get better.
Right, they don't get better.
Complications all the time. 20% at least of the hospital admissions are due to medications that people take. We all know this, but we don't have the will to act, to do the right thing, somehow or other. I don't know.
Oh, well, it is disappointing in some way, but that's why we're doing these webinars.
The same story Gustavo's told for the treatment of chronic coronary artery disease with catheterization. Same story. Just as much money to treating multiple sclerosis, rheumatoid and other inflammatory arthritises. These arthritides, they're arthritides, correctly. Treating these people with these powerful, expensive biologics that increase the risk of death and all kinds of complications, cost $35,000, $45,000 a year. This is again criminal behavior. The multiple sclerosis people, same thing. I have no kind words for your actions. You're nice people, but your actions are evil.
Right.
There you go. There I go again. There I go again.
I got you started. Well, let's go ahead and Dr. McDougall take one more question and then finish for today, if you don't mind.
That's fine.
Okay. Julie asked, "What do you think of glycemic index of foods?"
It is an interesting quality of food that misleads people into taking actions that are incorrect. For example, the glycemic index of a Snickers bar is 67%. The glycemic index of bread is 119%. So you would say, obviously, Snicker bars are better than bread. It's just one quality. When you eat, your blood sugar is supposed to go up. It's supposed to go up. There are other qualities of food. There's the fiber content, the protein content, the vitamins, the minerals, and so on. There are all kinds of qualities of food, but people have latched on glycemic index. This index was invented by David Jenkins, who's been a friend of mine for 30 years. And I believe, I have to say this, and if David hears this, I apologize for him taking any offense, but I still think David Jenkins is confused about what he developed. And he does not understand its proper use, or at least he's not communicated to the public, or that I have heard, that the glycemic index is something that should not guide the choice of foods. It should be considered, but it should not be the above all guide. And David and I are friends, and he may take this nice or not nice, but that's what I feel about it.
Well, but doesn't it matter that we don't eat isolated foods, that we combine foods and that makes a difference in the glycemic index, or that's not true?
Well, yes, absolutely what you said is true. If you combine one glycemic index food with another one, so you take Snicker bars and Babe Ruth bars and fructose syrup, and yeah, you can combine all of those together and you'll get a different percentage. What is important is that you know that the right foods are starches, vegetables, and fruits, period. And what other, if you want to say that they're white, I'll just go into this one. People say, don't eat white foods. They say, eat colorful foods. Well, what is the ultimate in colors? It's white. White is the most colorful of all colors. What is the least colorful of all? It's black. So when people say, don't eat white foods, they're thinking white sugar. Okay. Well, we talked about how white sugar rots teeth, et cetera. They're talking about white bread and white rice. Yeah, they're not ideal either. But how about cauliflower? How about white potatoes? How about, I don't know, you can probably think of a half a dozen other white vegetables that are excellent for you to eat. White is the ultimate in color. If you're looking for color in food, eat white potatoes. Potatoes are the most phenomenal food that I'm aware of. Well, maybe sweet potatoes are a little bit better. But if I had a choice, I'd live on potatoes or sweet potatoes and water. If you just gave me one food, it would be sweet potatoes and water. Or potatoes, white potatoes, any kind of potato, purple potatoes. I don't care.
Any kind of potato.
Yeah, just give me a potato. Yeah. I'm a potato guy. I'm an Irish guy. Give me a potato. Give me a potato.
Oh yeah, no, me too. I must say, for people that don't maybe know a little bit of my stories, that I lost 70 pounds really eating potatoes and sweet potatoes. And thank you, Dr. McDougall.
All right, thank you, folks. And we will not be with them next Thursday. Is that right?
So next Thursday, we're not having a webinar because in the United States it's a thing. And so our next webinar will be the first Thursday of December.
Okay, good. Well,
so thank you, Dr. McDougall, again for being here.
I want to add one thing, Gustavo, is Thanksgiving is the healthiest.
And we will see you next on December, the first Thursday of December. Yes, please.
Can I say one more thing?
Yes.
I want everybody to keep in mind, look at the picture. Thanksgiving is the biggest feast of the year, but it also happens to be the healthiest meal that most Americans eat. It is the lowest fat meat. It is full of bread dressing, potatoes, vegetables, and that's the biggest feast of the year. And what happens after Thanksgiving is people go on to bigger feasts for breakfast. They go to Burger King for lunch. They go to Dairy Queen for dinner. I mean, it's almost too much. Anyway, those of you that are going to have Thanksgiving, Mary and I are going to be having a pumpkin, as she told you, bread dressing, various kinds of vegetables and potatoes, mashed potatoes, and it'll be a big hit for all our family, including we're going to have most of the grandkids here. Anyway, I hope you have a nice holiday too.
Well, we wish everybody a happy Thanksgiving. Happy Thanksgiving to you, Dr. McDougall, and we'll see you in a couple of weeks.
Yes, Gustavo, and thank you for another excellent coordinated presentation. Good job, all the way from London. Okay. Bye-bye.
Okay, bye.
Bye.
Let's see.